Okay, so we are going to talk about new ways, new approaches to minimize stress and distress when handling dogs. And I want to remind you of what we started with last week, which was defining welfare, because we don't tend to think of this often enough in small animals. And we're thinking about the well-being of companion animals, emotional, cognitive, and physical, that we have to evaluate this situationally. And that the effects can be time delayed and penetrant, and the components of well-being intermingle these three components, the emotional, cognitive, and physical, and they co-vary mechanistically, and it requires objective consideration of the effects of our actions on an individual basis, not on our intent. And this matters for this talk because we're going to talk about restraint. And we need to define restraint in terms of what the animal considers restraint, not what we intended for the restraint to do or to be. And Katie said, given the seminar we'd had for 2 hours before this, I hope you're going to define stress and distress. And I said, actually, I was going to focus on defining restraint, not stress and distress. But let me, before I define restraint, talk just quickly about stress and distress. Stress in terms of a stressor is something that you do or that happens to an individual. The stress response is the physiological system response, generally involving the HPA axis and a bunch of cognitive stuff, designed to return you back to baseline. It's meant to be a response to an emergency and a restorative process, so that you have a homeostatic mechanism. Obviously, when something goes wrong, you can suffer as a result of that. And that very often, but not always, is distress. And you can have benign stress that doesn't have downstream effects, which people have called eustress. So we're mostly in the zone of distress and restraint today. So what's restraint? Interestingly enough, if you just look at a series of dictionaries, there are a range of definitions, but this is the Cambridge Dictionary, and it's where you control the actions or the behavior of someone by force. And I think that really works for what unfortunately happens. It may not be what we intend, okay? And especially in order to stop them from doing something. Well, that's why we are restraining animals. We're stopping them from doing something that would maybe be injurious to us or get in the way of caring for them. And it's interesting that they talk about limiting the growth or force of something. This is almost an agricultural, horticultural description. But I kept this because this is what we're doing. We're limiting the growth or the force of our patients. And when I think of growth, I just think of a variety of other behaviors that they could have offered instead of the behavior they're offering. And when you look at the outcome of restraint, it's an interesting literature out there. This is from the restraint of humans in psychiatric medicine literature. And this says physical restraint has an impact on the patient's psychological conditions, such as helplessness, tension, anger, fear, and trauma. And they emphasize the word trauma. The restraint action also leads to physical effects. In other words, these are all psychological, mental, cognitive, and emotional effects. The physical effects could be dehydration. We see that in our patients. Choking, we see that in our patients. Asphyxia, we probably see that. Aspiration, urinary incontinence, injuries. We certainly see urinary incontinence, anal sac incontinence, and even deaths. And we see all of those things. When you look at Grandin and Shivy's 2015 paper in animals on large animals, they note that when some animals are restrained, they react with greater agitated behavior and higher cortisol, glucose, or lactate. And these levels are all higher when you compare them to other situations. Restraint for veterinary procedures may be very stressful for one animal, and for another, it may be low stress. A major factor that is associated with the intensity of either a physiological or a behavioral response during handling is previous experience. Okay, now this is for a large animal. The exact same thing happens with small animals, and it doesn't get the same type of attention. And that's why we're focusing on it today. I also love that they noted that the response during handling is affected by previous experiences. And the implication in this paper is that if you had a good experience, that it will be better. But I also think we need to decide or think about when you have a bad experience, what that's going to mean down the road. And the AVMA has a policy on restraint that talks about humane, safe, and physical restraint is and everything that's in blue and italicized, these are not my words, these are the words taken from these sources, is the use of manual or mechanical means to limit some or all of an animal's normal voluntary movement. It's exactly what the human definition talked about and what the Cambridge definition talked about. But here it's for the purposes of doing good or something. Examinations, taking a sample, drug administration, therapy, manipulation. The method used should provide the least restraint required and should minimize fear, pain, stress, suffering for the animal, and every effort should be made to ensure adequate and ongoing treatment in animal handling and behavior by all parties involved so that distress, and physical restraint are minimized. Now, I find it interesting that they put distress in the same sentence as physical restraint because they know that they co-vary. Where it's not emphasized, but it's implicit here. Where appropriate, the animal should be acclimated to the method or device used for restraint so that you mitigate fear and distress. Again, it's not explicit, it's implicit, but if you just go and do this, you're going to scare and distress an animal. And in some situations, chemical restraint may be preferred. Whenever possible, it should be planned and communicated clearly. The BC SPCA talks about handling and restraint, but in much more proactive terms. Here it is. This causes stress to animals. In other words, a provocation of the HPA axis and the homeostatic mechanism of all organ system responses. Excessive or lengthy restriction of movement can quickly change an animal's experience of stress into distress, and an animal may continue to be in distress even if they appear to recover rapidly after the handling episode has ended. If routine handling procedures are aversive, animals are very likely to develop anxiety and show exaggerated stress responses when approached for handling again. They took everything that you saw before and put it in a statement. And as a result, here's their position statement. It's opposed to handling restraint practices that result in injury or additional fear. Individuals who handle or restrain animals should provide the five freedoms and maintain welfare standards that are transparent and current with existing scientific research. And the method of handling restraint used should be, and these will be the same things as you saw in the AVMA statement, the least physical and most effective method available, and they paired these, which is a difference, be applied for the minimum amount of time necessary, that's an addition, minimize fear, pain, stress, and suffering for the animal, that's said a little more clearly, and protect everybody from injury. That was missed in the AVMA statement. The remarkable thing about this statement to me is it says it applies to animal guardians and all animal-related businesses, including grooming salons, commercial dog walking operations, pet stores, daycares, veterinary clinics, boarding and breeding operations. And I think we are a long way from achieving that, and we have no regulatory and no monitoring capabilities over most of these things. So, what I want you to begin to get your head around is that restraint can be mental or physical, and you can be trapped and restrained by a situation. Think of weighing animals on scales, okay? Most of us don't think of that as entrapment, but it certainly could be. And when we look at restraint and distress, some of the things we could look at in terms of scales, and we tend not to, is increased glucose levels, increased creatine phosphokinase levels, increased lactate levels, changes in cortisol. Very much depends on your cortisol axis beforehand, what direction it's going to go in. Increases in heart rate and decreased heart rate variability, increased reactivity, increased future fear and anxiety, increased future avoidant behaviors, and possible changes in the fight-flight axis of the sympathetic response, depending on whether you react reactively or proactively. And you will see this when you try to do things like put an animal on a scale. And what do I mean by reactive or proactive? Proactive responses are primary and comprised of methodical and intention-driven behaviors. So the dog may take a look at the scale and just absolutely walk across the room and sit down and stop and just stare at you. That is a proactive response, not the one you wanted, but it's a proactive response. Reactive responses are secondary to pain, arousal, fear, impulsivity, in other words, inherent, innate, problematic impulsivity, as a reaction to perceived or threatening stimuli. Those are reactive responses. Now, I want you to remember that behavior is not static, that you are always learning and you are always changing neurochemistry, whether or not you learn from that. In other words, some of your innate responses then become trained in the neuromolecular definition of learning. Those neurons have learned, but it need not be conscious cognitive learning for you to have changed responses. So if you've got a reactive response that occurs because we scared you, the next time we put you on that scale, you could have a very proactive response. And instead of sitting in the corner, you could lunge for somebody. Okay, so don't think that because you had one response one time, you'll have it the second time. That depends on the history. Okay, so which experience do people really want for their client? And I should let you know that these are two of my dogs and my husband. And here's a dog who's sitting perfectly wonderfully on a scale that has a blue mat. Here's a dog who is sort of being manually restrained to stop falling off a scale that has a gray mat. At least these scales have mats. That's what I can say about it. But let me show you the videos. And because other dogs are barking in the background, some of whom are mine, I have turned off the volume. But this is a very, very scared dog. This is, in fact, one of our rescue dogs shortly after she was rescued. Notice my husband picking her up by the skin over her hips. Why? Because he's a get her done type. He's going to make sure she gets weighed, even if she's pinched and prodded and everything else. And I just asked him to get her on the scale. I wasn't quite expecting that, nor was he, actually, in all fairness. Compare that to this dog, who he walks on and walks off because there's another dog, again, one of my dogs in the way. And he's trying to get this dog to sit down, and the dog he's talking to the dog, he's pushing on the butt. I'm standing at the head of this dog, and I just get this dog's attention, and I ask him to sit, okay? And look at how happy he is. Now, there's an example of a dog who has been taught to do a variety of things and get on a scale. This poor dog had been subjected to a life of punishment and shock for 1.5 years before we got her. And all you're seeing are reactive responses. Proactive responses that were aggressive, she'd be dead. Okay. Toby, on the other hand, is only being encouraged for proactive responses that are correct. And look at the difference. So one of the places we see as ultimately stressful, and this has shown up in a number of research papers, is weighing the dog. So again, we can come back to some standardized set of scaled evaluations, and clinics should be using these. Why? Because they tell them when they have a problem. And you could call Toby either extremely friendly, outgoing, enthusiastic, solicitous of attention, and eagerly gets onto the scale, which he did. Or you could say he was calm, relaxed, seemingly unmoved, walks easily onto the scale, and he sat. He walked easily onto the scale and sat, but he was very enthusiastic. Give him a 0 or a 1, I don't care. Missy, on the other hand, was extremely stressed, barking, howling. She wasn't barking or howling, but she tried to flee, needed to be looked up, forced to get on or stay on the scale, can't stay there for up to 10 seconds without help. And this is what these scales do best. We don't have to struggle for non-research purposes, whether it's a 2 or a 3 or a 3 or a 4. You make a rule in research. Our rule is if you can't decide if it's 2 or a 3, you give it the higher number. If you can't decide if it's 3 or a 4, you give it the higher number. You make your mistake in one direction. You can do the same thing in clinics. You may or may not be collecting the data, but what you are doing is evaluating the dog in that moment and what your intervention did to them. And it wasn't pretty here. And we know this. So as part of a study that my resident, Dr. Camille Square, is doing for her master's degree on the effect of veterinary visits on dogs and changing the way we examine dogs, we had a rule for how to deal with scales. And we had to follow the Atlantic Veterinary College protocol. We have movable metal scales. They are generally placed flush against the wall, and they don't always have a mat on them. So our first rule was the first visit, and everybody in the study was treated the same way at the first visit, the interventional group too. It was a baseline week, and then they had 3 weeks of their trials. So scale against the wall, no mat, no treats. If they could do it, great, we gotta wait. We evaluated them using the 5-point scale here. If they couldn't do it, we added a mat. If they could do it, great, we evaluated them using the scale. If they couldn't do it, we moved the scale. We moved it at least 1/3 of a meter away from the wall, because that's enough space for a dog to walk all the way around it, and it gives them some ownership over the space, and they're not stuck against the wall. So if they could do it, yes, we rated their behaviors there. If they couldn't do it, we lured them on with a treat. Everybody could do this step. Everybody could do this step. That strongly suggests that in practice, cut your losses and skip to here, okay? But it does give us a nice response surface for the rest of the dogs in our study. We all want to be safe, provide excellent and comprehensive care, and live a less stressful, more enjoyable life. Our patients also want to be safe, benefit from care, and live a less stressful, more enjoyable life. How do we get there if we want to live, and this is supposed to be if, not is, the lovely thing about this mode vitamin is I can fix it, if we want to live in a post-restraint world? How do we get there if we want a post-restraint lifestyle? Well, there are only so many things we can do, and they're pretty obvious to anybody who's thought about behavior. We can alter the physical and sensory environment. We can certainly enhance the behavioral environment. Behavioral environments in veterinary clinics tend to be quite challenging rather than something that dogs want to engage in. And we can use medication, and I'm going to go through these briefly. Altering the sensory environment for dogs who don't do well with noises or the lights in clinics. You could certainly, using a calming cap, alter the light perception. You could certainly use rec specs. These are rec specs to alter the way they see certain types of light. You can use mutt muffs. These are mutt muffs. You can use rec specs ear pro. These are a military derivative product, rec specs ear pro. The nose is here, the neck is there. They just fit tightly and they'll block off most noise. They also provide a little pressure. They leave the eyes available, so they don't do what calming caps do, but they can have some really quite lovely effects. None of these things have been tested in good studies. And thunder shirts, which people commonly use. There is one study on thunder shirts that shows a marginal effect of benefit, but it does no harm, and it's got a money-back guarantee. We can change the lighting. We can play music. Studies have shown that humans, i.e. the vets, like classical music. Dogs like Bob Marley, and cats like cat music. And what is cat music? Meow, meow. In other words, they want cats doing affiliated sounds. We can use sound absorption panels or white noise. We can use cool mats, because if you're panting and you're upset and you go to sit down and suddenly you realize, oh my God, that's nice and cool. I was getting so hot. It's a reward. And we can use flooring that absorbs noise. Most people don't do most of these. The behavioral environment, food toys, including licking mats, and we use a series of them. We actually use these in clinics. Some dogs like hard food, some dogs like a bowl that wobbles, some dogs like stuff that sticks. So we stick this to a counter or a window. Here's the sticky part. You smear it with something. And we're using these clinically all the time. You can use targeting and rewards. You can take the dogs for walks and do a lot of stuff outside or while they're walking. You can have windows. We have an exam room that basically has floor to ceiling windows on 2 sides. What a difference in how reactive the dogs are. It's such an improvement, and the clients are calmer too. You can have loads of space, as we do, and allow the dog to go where he wants. Help them to make a series of choices and work with them where they are. And you can teach dogs to go to your mat. You can have that mat go home with them. The clients can start with a mat from home and bring it in. In the study, in the interventional group, Camille gave people mats, and those people trained their dog to sit on that mat, to offer body parts on that mat, and to be massaged on that mat. And that mat came back to every visit. And as soon as the clients put down that mat, the dogs would go over to it. It's a familiar safe haven. What about medication? This is a paper that just came out a couple of weeks ago in the Canadian Veterinary Journal. This is the table from it. In the last session, I discussed some of the issues with the studies we have. It sums up to, we don't have enough studies. But these are all of the studies that exist on all of these medications. And the summary of this is this slide. So there are studies for gabapentin in cats, no dose determination studies published in dogs, but I understand they're coming. So we're looking at 20 to 40 milligrams per kilo every 8 to 12 hours in dogs, and 10 to 35 milligrams every 12 hours in cats. There is now a published study of pregabalin in cats, and it's 5 milligrams per kilo as needed. This is Lyrica, which is how it's currently available. You should also know the cats hate the taste of this. Alprazolam, there are studies for dogs, 0.02 to 0.04 mg per kg, and for cats, much lower than that, no published studies. Lorazepam, no published studies for anybody. Traditional ranges for dogs are 0.02 to 0.5. That is not a typo. You'll work your way up slowly. There's a range for cats. This is a per cat. Notice these are per cat dosages. So 1/4 to 1/2 milligram. Diazepam in dogs has been published at this dosage, 0.05 to 2.0, but you should know that diazepam undergoes a series of pathways. It becomes a desmethyl compound, which is itself very, very bioactive and has an incredibly long half-life and is very sedative. That N-desmethyl diazepam becomes oxazepam, which is available as a parent compound, and that then undergoes glucuronidation. If you're giving diazepam, you're giving 3 active compounds, and you need to know that. And in the studies that have been published, it is quite sedative for many of the patients. Now, that may be what you want, but you shouldn't go into this without thinking there's not going to be a long half-life. And in cats, the half-life is very long. Clonazepam, again, no published studies, 0.01 to 0.1 mg per kg. You can try, and this is what I do, you can try a lower range, 0.01 to 0.05 mg per kg is a basic dose, and increase it as needed. So you're looking at 1 to 2 milligrams for a 20 to 25 kilo dog. Cilio now has a number of papers for situational anxiety, so vet visits, dogs being left, noises, of course, all of these types of things. Clonidine has a paper of case studies where the dosages were 0.01 to 0.05, so there are data. And for cats and dogs, of course, there are data on clonidine and trazodone, where the dogs are 3 to 10 mg per kg, Q to 8 hours. No dose determination studies, very, very wide range of dosages. And cats are 10 to 35 milligrams per kilo, 50 milligrams per cat on average. Again, no dose determination, and a very wide range of dosages. So this gives you some idea of what you can do, as we discussed last time, before you come to the vet, or when you've screwed up, when you've suddenly realized you put the dog on the scale and it's already a basket case. Your choices are basically the benzos. Cilio and wait 20 minutes, or gabapentin and wait 30 minutes to an hour. You could also give clonidine and wait 30 minutes to an hour, but your real choices here are going to be the benzos and cilia. Trazodone has no use here for you. So what thing didn't we mention? We didn't mention doing it differently. And I'm going to spend most of the rest of the talk talking about doing it differently. Get the patient to work with you by making it easier for them to do so, and by fitting in with their signals, understand what they're telling you, learn to read their signals, learn to understand their needs and desires. I don't want cooperative care. I want collaborative care. I don't want to teach the dog just to cooperate. I want them to help me. And dogs and cats and horses and everybody else, you can enlist their help, but you have to tell them what you want them to do, and you have to teach them to do it. So here's an example of the patient's stress, i.e. from restraint, on our ability to do our job. I took both these samples. I took them the same day from the same dog, separated by 5 minutes from the different legs, okay? The one on the left, I took with a syringe and a needle where I had to hold off a vein and hold off a leg, which is stressful. The one on the right, I took with a double-ended catheter system in a closed system that relies purely on pressure, where you don't have to hold off the veins. And these are called wing blood collection sets, or vena sets, or vacu sets. You'll see them, they come under a bunch of different names. This is the part that goes into the tube, and it's got a stick guard on it. If you're not used to these stick guards, these are widely used in human medicine. If you're not used to these stick guards, I'm going to give you one piece of advice. Aim for the very center of the tube and shove it in. It will go right through the stick guard, but if you get that up against the thick part of the rubber end of the tube, you're going to be in deep trouble. It won't go. This is just a standard butterfly end. And what you do basically is you put the butterfly into the dog. When you see the flashback, you shove this into the tube. And many of the tubes that are meant to be automated have a very, very tiny center soft spot. So you may want to take a look at your tubes and decide what you're going to do. Soraya Warbe-Diaz, a person who's has many clever ideas. She's a board certified specialist in, and I just noticed I misspelled her name, board certified specialist in Florida. For spot tests, what she does is she uses a tuberculin syringe. Why? This is just a regular 1 cc syringe with a little 26 gauge needle on it. Look at how tiny the tuberculin syringe is. And all you need for many of these ELISA tests is a spot. This is something that even without topical anesthetic, you're likely to get very, very, very easily if you're distracting the dog or rewarding them for sitting still, and has a lot of uses for cats, puppies, kittens, etc. Before we do anything that hurts, I'm not going to vaccinate an animal. I'm not going to give them sub-Q fluids. I'm not going to take blood. I am not going to put in a microchip. I'm not going to empty their anal sacs. I'm not going to put in a catheter. I'm not going to do, I'm not even going to put in a syringe for topical lidocaine that I'm going to inject if I'm just going to do, if I have to cut through their skin, relatively minor procedure, without using a topical numbing agent. And that tends to be lidocaine or lidocaine prilocaine. And I've given you 3 different versions here. The 5% lidocaine only ointment comes in tubes. It comes in flavored varieties, comes in a bunch of different forms. They are all very thick and viscous, and they hang around for a while. On warm skin, they will melt, but they are not as user-friendly as the lidocaine 2.5% prilocaine 2.5% cream. The lidocaine jelly, which is just 2%, you may need more of it, but if you've got little puppies or kittens, or you've got things with very curly coats, this penetrates quite nicely because it is a jelly, and as it warms up, it just sort of and smooths out. One of my nurses who did a lot of nighttime intensive care work loved this for very furry little poodles and for cats at night. All she would do is try to get them this on a limb, and while they were sleeping, just edge the limb out, and she could get any sample she wanted without even waking them up. And this is her, this is Jess. She's putting lidocaine on some study dogs. These are rescued greyhounds, and we did not shave this dog. They often have worn back leg skin patches. And notice she's not holding off a vein. She can see the vein. What she's doing with her thumb is she's got her thumb next to the vein. She puts the butterfly catheter piece in, there's the flashback, and she sticks it in a tube, and the tube is full. The client is over here, and all of these photos people have given us permission to use, and she's letting this dog lick a Kong that has cream cheese, dog standing on a yoga mat so he doesn't slip, easy peasy. She has two of these dogs who look almost identical. Here's the second one where you can really see the blood filling the tube. And if the dog will stand still, all you need to do is just leave the catheter there. The holding off, the restraint, especially on scared dogs, on arthritic dogs, taking their neck and pulling it away, they're immediately reactive. If they can stand up and help you to use pressure, and you can just put your thumb against the vein, nobody needs to hurt them or take away any of their freedom. They can learn to do this. My dogs are taught to do this, okay? And it's fast, it's easy, and you're done in seconds. And you're gonna get to see a video of one of these dogs. And again, I think I've turned down the volume because this was during a cognitive study, and this place is an echo chamber. So you'll see this, and Jess shows up with all her supplies. And again, these are retired rescue greyhounds. You're only going to see one of them, but they, you know, they're well muscled, worn patches. There's the flashback. There it is. Dog had lidocaine put on its leg. There's your sample. She's just completely filling a large tube for a genetic sample. And there we go. Easy peasy. This is a fearful rescue dog. Now, it's a lousy video from your perspective because you're not seeing Jess put this in the vein because the client's arm is here. She doesn't want the dog to wander off, and the dog is at no risk of wandering off, even though she's holding the harness, simply because I showed up with a handful of hot dogs. And you'll get to see what that does here. But this is a very fearful dog, rescue dog with an uncertain history. She's afraid of loads of things, participated in the study. She's older, she's a little arthritic, she's not great at moving around.
And it's absolutely traumatic to the dog. It's what we're trying to teach her. The challenge is her skin. Her skin may make this almost impossible.
She also has a skin disease. I don't know if you can see this. She's got some lichenification and baldness of her skin due to an endocrinopathy.
She's got that genetic.
You can see she's got weird patches. Jess is in, by the way. She's standing there and she's happy. Here's this fearful dog who's thrilled to be doing this. She doesn't need to be held on to. She is going to sit. But there she is. She did that really well. Here's an enthusiastic golden. Sorry. Here's an enthusiastic golden. Big dog, very hairy dog. This is going to be your big problem, is that these are hairy dogs. Goldens have veins that move. Camille can now tell you this. I think she could rank dogs by how wiggly their veins are. But there it is, you know, and notice how, what I want you to pick up on is how relaxed these clients are. They have been told this is novel, this is going to be different, it's going to be fun. These dogs have already undergone a 45-minute cognitive test where they had a load of fun. The dogs are coming into this with a good cognitive bias. The clients have a good cognitive bias. No one's distressed. This dog participated in the study. This will be the only slightly fearful dog you see because this dog is owned by a veterinarian who is holding this dog. And Jess is going to spend all her time trying to convince her to not hold off the vein. But look at the difference in this dog's body posture. Because why? It's the only dog who's in a restraint posture.
It's such a huge difference. But I was really happy that, you know, it's great. All these people,
Show me what you took. You're good. Yes. No, you don't need to.
Yeah.
There's a couple Jesses. You know what we use a lot too, going back to what you were just talking about, since cats especially. So many when our dog
Now the dog's getting calmer, but that posture and being held like this is the most upset of our dogs.
Systems that you don't have to hold off on so many dogs. That's the thing that triggers, and especially if they're older and they're sore.
And for young, energetic dogs, you may need some help to do this simply because they're wiggling, they're moving, they've got tails that are, you know, doing all sorts of things and communicating how happy they are. I think at this point in time, this golden, I want to say he was 7 months of age. I'm in the zone. We'd been seeing him since he was a young pup. And I'll turn this down so I can talk. My job here is to keep the tail out of the way, okay? Because Jess was going to be hit in the face with that tail. So my only job here, and I'm just supporting him. I've got an arm under his belly. He's getting his stuffed Kong. I've got an arm in his crotch. I'm probably tickling his prepuce and testicles there because he's a male dog. And after working on working dogs, I realized that can make a real difference. But there she is. Wiggly veins, lots of hair. There's your sample. Okay, on a young dog, and this dog will never learn what it's like because their veterinarian received a copy of this presentation, will never learn what it's like to be that scared. Now I'm going to show you a video from Camille's study. Here's Camille showing up with her tubes, you know, and she's going to do the blood draw component of this now. So he's on his mat. There she is with her tubes, her alcohol, her gauze pads, her catheters. Okay, and you see him licking this bowl. This is the assistant, and bear in mind the color of her fingernails because I'm going to show you another shorter video. And you can see how all he's doing, he's not being really held. He's up there. And mom, pay attention to the timing of this because mom puts her arms around him as she knows that Camille is getting ready to stabilize the leg. You saw that beautiful vein? Okay, this is a second-year student helping. We need a few tubes of blood for this study, so Camille's changing out the tubes. There she goes. Allison holds it off. They're done. Okay, but I want you to see his face. One of the things we did for this study is we bought a really high-density video camera for this study. And what I want you to see is his face in this video. And you'll watch for the nails because when Allison went to hold the dog, you'll see her pink nails. But you'll see that the only thing, he doesn't flinch when he's stuck. He doesn't do anything. He's got one of those wobbly bowls. This was the toy he chose to go home with at the beginning of the study. The client reaches over just when Camille, she knows Camille's got all the stuff, so that she wants to let him know to stay still and it will be okay. She's more worried than he's worried. So he's like, why did you stop me from having my little wobbly bowl thing? And then she gives it back to him. Okay, there's Allison's hand scratching him in the place she should be scratching him, in the lower front of the chest. He's being stuck, and there are no visual signs of that on his face. When they come in for the exam, they have lidocaine put on all 4 limbs. Okay. And we always try, as I said last week, to go for a back leg pain. This has long since been over. And you could not tell that from his face. And that's what I call a success. So, you know, these are skills that we want dogs to have. At what age do you best teach this? Do you teach this at 10 weeks of age? Do you teach this at 20 months of age? This is Gabriel at 10 weeks. This is Annie at 20 months. What do you teach? Well, you teach it at 10 weeks of age. Gabriel is already having the experience of lidocaine put on veins being manipulated. He sits, he looks, he targets, he follows, he takes a deep breath. He's used to the manipulations. He picks up his legs. He sings stethoscopes. He can stand still. He can give his belly. He can lie still on his back. Why? Because these are lifelong skills for when it counts. Because at some point, it counts.
You have wonderful people.
This is my dog, Linus, whom we unfortunately lost in July at the age of more than 14. This was 4 years ago when he was diagnosed with a stage 4 mast cell tumor. Now, this is a technician in training, and I had said to her before, just stabilize the leg. She's trying to hold it off, and Jess had said to her, you saw Jess shake her head. You don't have to do that. He's in the chemo room. Nobody's holding him. What we have here is baby food. Nobody's doing anything to this dog. Okay. Various chemo appointments, we have videos of them all, but every step of the way, he has his lead attached to his harness. He certainly doesn't need it. There you go, he's about to have his chemo. That was the flush. They're hooking up the T-set and everything. He's fine with all the tape. And even when they go to take this off, and that's the spray that releases the tape. And Jess says to him, this is going to feel a little cold, Linus. It might scare you and there will be a sound. So she tells him something's happening. And there it is. And she peels everything off afterwards. At no point was restraint involved. Why? Because that is collaborative care. That is getting the dog to work with you. How do we start? Okay. Maybe the pet sits in the owner's lap. Is that what they normally do? If they do, yeah. And are they willing to do it there? Yeah. Can you apply lidocaine and do an exam? Yeah, you're done. What if they don't do that normally or they won't do that? Ask the owner. Is there a place they're more comfortable? Unfortunately, everybody in our study said, oh, they usually take the dog away from me, and it wasn't just COVID. And I really recommend that they don't, because the act of taking the dog away may itself be a stressor. So if the client has a suggestion, try it. If it doesn't work, it's like no suggestion. Restrain gently, if it's a smaller dog, on the table with treats. And by restrain, it's the restraint we used, where you just gently put your arms completely around the dog so that they can't fall off. They're on a mat, they have treats. That doesn't work, they get a 5-minute break for treats and water. Owner can try holding either on the table or on the floor. And if they're sitting on a chair, maybe that will work for them so that the owner can sit there and reward the dog. And if it doesn't work, they abort it. And we try something else with meds. No more than 10 minutes goes into this before you try something else. And I think that we have to remember that when changing behaviors, you have to realize that humane handling involves learned trust. So, dogs don't automatically roll over on their back and hang upside down. They have to learn that this feels good, that nothing will happen, that they get rewarded. They don't automatically put their paw on your hand just so you can see where the nails are long. With Flash, I never even held off his foot because I could see where the nails were long. I would peel back the hair and just trim his toenails like that. And yet, toenail trimming gets dogs killed every year. This is a video of a border collie who was slated for euthanasia, according to the vet, not according to the owner. He'd been thrown out of 4 veterinary practices because of his responses to physical exam, blood draws, vaccinations, having his toenails cut. And the last time he was thrown out of the vet's office, the vet said, "You have to euthanize this dog. This dog is going to kill somebody." This dog was 18 months of age. So let me show you what we did. The client stopped on the way home and got the supplies necessary to do this, and then worked with the dog. And I see that there are chats and questions, and I will answer them.
I know, the treats are all good job.
Now, in truth, this woman is a PhD in psychology, and she had already clicker trained the dog. She wants an agility dog. She got a board and some sandpaper. This video is 15 years old. This isn't a novel approach anymore, but not everybody's doing it. And this dog can learn to do his front legs without any trouble. If your dog shimmies, if they scratch, if they'll get on a treadmill, if they'll shake back and forth, if they'll dance in circles, if they can learn to scratch on request, they can all do their nails.
We're not doing this. We get it.
Notice she gives him a break every once in a while because she's a good trainer. And her timing with the clicker is excellent. So he comes back, he scratches, wonderful, and he'll get another break in a minute. Perfect. And then people complain that dogs have back legs. Yes, yes, they do. And this is what she did for that.
Okay. Ready? Pause. No.
Now, not every dog is really good at turning upside down like this, but you could accomplish the same thing by having a dog walk down a set of stairs and stop. And if their foot's at the edge of the stairs, you could just trim their toenails, front and back, without ever touching their feet. You can do loads of creative things, but it starts with accepting that we have to change what we do and that we're not going to accept the distress and stress that's associated with classical restraint. And I think this comes down to what good relationships are. They're not based on fear and restraint. We have choices. Dogs can learn to help us care for them without distress. They're cognitive. We can do better and understand more, so can they. But we can't do this unless we measure and record what we're doing now and step back and ask ourselves if what we're doing is benefiting the dog. All you have to do is look at the face of that Dalmatian to realize that's a great choice for him. That was a rescue dog who initially had been a fearful dog. She worked with that dog. That could have been a horrible situation for that dog. And it was wonderful because we took a step back and asked what we could do that was different. Okay, there's all the contact information, my email address, Twitter, website. If you need consults, we do distance consults. The forms are there, the journal. And let me just say, Katie said it. Katie has all this stuff about race. That's excellent. And let me look at the Q&A. What would be your go-to dose if you screwed up and you needed to give alprazolam? I can give you a per dog dose, which might help. I can give you, when you think about it, alprazolam comes in 0.25, 0.5, 1, and 2 milligram tablets. And for a dog that is about 20 to 30 kilos, maybe I might try a 0.25 milligram dose. And that is usually what I do. A very fearful shepherd mix that was in a clinical situation recently and just couldn't relax. We gave the dog 0.25 milligrams in a ball of cheese, and 20 minutes later, it was a different dog. And then as the appointment, which is 3 hours long, went on, the dog was getting a little more antsy. So another hour later, we gave it another 0.25, and it was great for the dog. So you're going to be in the zone of 0.2 to 0.4 milligrams per kilo as a starting dose. How long should you wait after applying the lidocaine before you can draw blood? Camille, as I said, and this is the way I do it also, Camille put the lidocaine on all of the legs, because what if you blow a vein? We have a protocol for when you give up. So she put it on all of the legs right at the beginning. And that exam in animals that were cooperative, if you looked at the time, it's 14 minutes from when the dog walked in the room, but we didn't start the exam then. So you're looking in the range of 5 to 8 minutes before she gets to the blood draw. In as little as 3 minutes in humans, there is an effect. Dog skin is as vascularized and possibly a little more sensitive to this. The literature for cats and dogs says 30 minutes. It's all cat literature, by the way. Most of it's cat literature. It says 30 minutes, but that's the smallest interval they looked at. One of the people in this study was a human pediatric nurse who's doing similar studies in children. And they wait 3 to 5 minutes in babies and young children. And the remarkable thing she said was, she said, I have never seen a veterinarian use those types of catheters. I said, well, this is part of changing opinions. And she said, but it's all we've used for years. And what a difference. Okay. What size needle? The needles on those catheters, we stock both 21s and 23s. I prefer the 21s for most dogs unless they're teeny tiny, and then the 23s. You need to make sure you're really in the vein if you're using a 23, because if you're up against the edge and you just twist it, it'll be fine, so that you make sure that the bevel isn't sitting against the inside of the vessel. Remember, you've got 12 inches of tubing. Does the tubing, by the way, change the quality of the blood draw? No, that paper has been published and it was well studied, and it does not change any of the parameters. But you want to make sure you've got decent blood flow, or with a 23 gauge needle, you could certainly clot it. Don't forget that for Eliza's Soraya's using 27 gauge or smaller needles, because all you really need are a few drops of blood. How long do you leave the lidocaine 2% jelly on prior to blood draw? Jess left that on a little longer because it is 2%, but she also sometimes would put more on once it had saturated down. So what she would do is she would sort of give 10 minutes or maybe 15 minutes, and that would work. Oh, puppy waking up. Which additional med would you use for a 3-year-old shepherd with separation anxieties being on Clomicon, 2 mg per kg per year with some improvement? Okay, let me tell you something about the 2 mg per kg per year with some improvement. I published a paper this year in the journal Animal Behavior. I'm trying to remember which journal it was. I think it was Animal Behavior, but where I looked back over some very old data to find some very interesting things. And one of the things that we had done in this study, and it was part of the Clomicon licensing study and a parallel study we did with it, We, after the study, kept everybody on 3 milligrams, 2 to 3 milligrams per kilo every 12 hours for a year. We converted all the dogs that didn't have a 90% or greater response to a 90% or greater response within a year. That's when we assess them, so it may have happened earlier, at the higher dose. So if you've got some improvement, get to 2 to 3 milligrams per kilo. The other thing is, if you've got a dog who is very fearful at the vets and they've got separation anxiety, you can add a lot of things to any of the TCAs or SSRIs on either a daily basis or an as needed basis. We add a lot of alprazolam to things. So we've got a lot of dogs on Q12 hours alprazolam and alprazolam at the vet. You certainly can add gabapentin, 30 milligrams per kilo to start, Q12 hours to a separation dog. You can certainly add Cilio. Cilio will be a little expensive to do Q12 hours. You can certainly do it situationally, or you can do it when the dog's in a bad state just before you leave, give yourself half hour to get out the door, et cetera, et cetera. So are you using lidocaine cream at vaccine sites? We are. And you'll notice that Camille took an alcohol gauze pad and wiped everything off the same way we would. You're not going to at that point affect the topical lidocaine effects. How does the butterfly needle stay in on its own? Simply, no one's moving. I mean, it's just going to sit there. The vessel and the skin sort of grab the needle. So unless you're tugging on the tubing, and there is an art form to this, because it comes in a curled up tube. And what you've got to learn to do is to hold the tubing in your hand. And I don't know if you saw that Camille was doing that. Get the catheter well seated. You've already unlocked the tubing because it comes with a little lock. You've already unlocked it. And, if the dog is moving or it's maybe not as well seated as you want, now is the time for an assistant just to come up and just put their hand against the butterfly. They don't have to hold anything off, just put the hand against the butterfly and you have no trouble putting the catheter into the tube. It does take practice. I brought in dogs. Camille had dogs. We practiced on a lot of dogs. And I think Camille can do this in her sleep. She reviewed all of Jess's videos. I have dozens of those videos. She reviewed all of those videos. And there's nothing like just giving it a shot. But this is just one thing we can do. So what did we talk about today? We talked about 2 parts of an exam: the scale and the blood draw. Everything that we talked about in between, the parallels from all of this can change. My dogs go to vets and they know, they're going to listen to your heart. Okay, heart. Sit, lie down, stretch out, show your belly, stand still, stand. There's nothing you couldn't have done to Linus. Because he knew all the words.